The top stories of a short week first, and then we talk about colchicine after myocardial infarction. Here's the news with Amy Herman.
Hi, everyone. First up, a study has found that people who recover from metabolic syndrome face lower risk for cardiovascular events than their peers who continue to have metabolic syndrome. In particular, over roughly 3.5 years, the rate of cardiovascular events was 15% lower among those who recovered. Next, researchers studied 360,000 children who went to the emergency department for injuries from non-powder firearms like paintball and BB guns over 25 years. They found that while overall injuries declined during the study period, eye injuries actually increased by 30%, and they often required a hospital stay. You really will shoot your eye out, kid. Elsewhere, a study shows that the average life expectancy in the U.S. started to decline in 2014, and this was largely due to increased mortality in adults aged 25 to 64. Some of the causes: more drug overdoses, alcoholic liver disease, and suicides in this age group. Switching gears, in honor of Thanksgiving week, infectious diseases expert Paul Sachs has shared all of the things in his field he's grateful for this year. You can read his post on the NEJM Journal Watch website. It's definitely worth a look. And that's it for this holiday week, but don't rush off yet to grab that leftover turkey and stuffing. Joe Elia has a new Clinical Conversations podcast for you next.
In an international study called the Colchicine trial, Dr. Jean-Claude Tardif and colleagues tested low-dose colchicine, a powerful anti-inflammatory, as a possible way to lower cardiovascular event rates after myocardial infarction. Noting that other anti-inflammatories have lowered those event rates, they enrolled and randomized 4,700 patients to either daily colchicine or placebo. All subjects had had an MI within 30 days before enrollment. During a roughly 2-year follow-up, significantly fewer patients on colchicine experienced the composite primary endpoint than those on placebo, 5.5% versus 7.1%. The study appears in the New England Journal of Medicine. Dr. Tardif directs the research center at the Montreal Heart Institute and is a professor of medicine at the University of Montreal. Welcome to Clinical Conversations, Dr. Tardif.
Thank you very much for having me.
Coordinating among 167 centers in 12 countries that could not have been easy. So bravo to you and your team, especially the people, the organizing staff. As you point out in your paper, colchicine has been around for a long time. How does it exert its anti-inflammatory effects?
Yes, well, it's a drug that has multiple anti-inflammatory effects, but it appears that the predominant effect is on what we call tubulin. And actually, colchicine blocks the polymerization of tubulin, and hence it blocks the generation of microtubules. And so by doing so, it will have an effect on inhibition of migration of white blood cells and proliferation of white blood cells.
The trial had a double-blind randomized design with placebo control, and you used low-dose colchicine. Was there a reason to keep it at low doses? Is it toxic at higher doses?
Yes, so actually the reason we chose the low dose of 0.5 milligrams actually was twofold. One was this was the dosage that was used in a prior but smaller trial called the low-dose co study, the low-dose colchicine trial that had been published 5 or 6 years ago. And second, indeed, because at higher dosages, colchicine can have side effects, predominantly gastrointestinal side effects. We wanted of sort of finding the sweet spot, if you will, of retaining anti-inflammatory effects, but actually trying to identify the dosage at which we would have good tolerability.
Okay, so let's get to let's look at the results. So in the introduction, I mentioned that the trial had a composite primary endpoint, and the endpoint encompassed a death from cardiovascular causes, resuscitated cardiac arrest, MI, stroke, and urgent hospitalization for angina leading to revascularization. So any one of those 5 endpoints would be a primary endpoint. And taken all together, you found this effect. Now, although the composite endpoint favored colchicine over placebo in general, the elements of the composite that, when you evaluate them separately, remained favorable to colchicine use were stroke and urgent hospitalization, leading to revascularization. Could you talk a little bit about that?
Sure. So you are absolutely right. We did reach our primary endpoint that was pre-specified, which was this composite. And you're right, there was a 23% reduction of the rate of this primary endpoint with colchicine compared to placebo, and we were powered for that. Now, you're also right in saying that if you look at the point estimate for the hazard ratio of all of these 5 components, they were all favoring colchicine. Not all significantly so, but that's not what we were attempting to do. Uh-huh. But yes, if you look at the point estimate, it was favorable for all of the components, CV death, arrest, MI, stroke, and urgent hospitalization for angina. But you're also correct in saying that while each of the components contributed to the main effect on the primary endpoint, it was mostly driven by the effect on stroke and urgent hospitalization for angina leading to revascularization.
Now, I noticed that pneumonia was more prevalent in the colchicine group. And so, as you explained earlier, the colchicine affects the ability of white cells to migrate. And I wonder whether that effect may have had something to do with the bit higher rate of pneumonia.
It's possible. So, first of all, obviously, we took a close look at that aspect for the reason you just mentioned. When you try to reduce inflammation and you could affect immunity. And one of the reasons we were taking a close look at that is that in a prior study with a different agent called the CANTOS trial with canakinumab, which is a monoclonal antibody to interleukin-1, in that study, there was a small but significant increase in septic shock and death related to that. The absolute effect was small, but it was significant. And so we took a close look at this in this Colchicine trial with colchicine. Fortunately, we did not see any difference in septic shock or deaths related to infections. But you're right, we saw a small but significant increase in pneumonias. It was the rates were 0.9% with colchicine and 0.4% with placebo, so less than 1%, small but significant.
So what are the findings telling you?
You mean globally? When I look at the totality of the evidence of the results, I believe that this is a significant finding in a sense that, not only did we reach our pre-specified primary endpoint, 23% reduction in a composite endpoint is quite large. If you compare it to other recent trials with often much more expensive drugs or sometimes injectables, most of these trials actually reported smaller relative risk reductions than what we reported. Not only that, but the fact that, again, the hazard ratios for all of the components of the primary endpoint were favoring colchicine, I think is telling in the sense that this shows to me the robustness of the finding. And then one thing we haven't discussed yet, we also looked at the per protocol populations of patients without major protocol deviations. We looked at the total burden of ischemic events, that is not only the first ischemic primary endpoint, but also the recurrent events. And there, the effects were even stronger in a sense that when we looked at the per protocol population, then the effect of colchicine was a 29% relative risk reduction compared to placebo, which is very large. And then finally, when we looked at total burden of events, that is first and recurrent events, there was a 34% reduction in the total burden of ischemic primary endpoint events with colchicine versus placebo. So when I look at the totality of those data, these suggest to me that colchicine indeed helps patients with a recent myocardial infarction. And then the pleasant surprise was the safety and tolerability profile was very good.
And another pleasant surprise, or it's not really a surprise, but colchicine is not an expensive drug. It's not as expensive, say, as in the monoclonal antibody.
Exactly, and I'm glad you're raising that point because I think it is a significant point. And I understand to a certain extent, price will vary from country to country. Now, I happen to be practicing at the Montreal Heart Institute in Canada. In Canada, where I practice, patients pay literally 27 cents a day for this. I understand it is more expensive in the U.S., but for me, it is difficult to justify prices that are extremely high for a drug that comes from a plant that's been around for 150 years. In my opinion, the cost of that drug should be very low. And this is relevant not only in the U.S., but that might be very relevant to have a drug that's effective, in emerging countries, in low-income countries. I mean, this has, I believe, global significance in the world.
Yes, you presented these results recently at, the American Heart Association?
That is correct. So we presented that as a late-breaking trial at the American Heart Association scientific sessions in Philadelphia recently.
There have been various reactions to it. As a matter of fact, the editorialist has a kind of cautious point of view. But I've detected some enthusiasm in other quarters, one of which was no less a person than Harlan Krumholtz of Yale University. And he tweeted, and I'll quote him, "This trial may be the star of AHA 19. This is a remarkable result. The question is, how much should it bother us that high-sensitivity C-reactive protein did not decline in the colchicine group? Does this need validation, or should we start prescribing tomorrow?" The editorialist is doubtful, though.
So obviously that's why we have scientific sessions and we have articles and editorials and, in high-impact journals, is that there needs to be a healthy medical/scientific debate. Now, you're right. I guess globally, when I look at the interactions at AHA, and I maybe can say a few words about the discussion that followed my presentation at the late-breaking trial session.
Sure.
And what happened in, globally, I would say overwhelmingly, response was positive. The discussant at the AHA session right after discussing our results was Dr. Aruna Pradhan from the Brigham and Women's Hospital. And, I think I can quote her saying that she said that this was a landmark study. I remember also Paul Ritker, who was quoted in newspapers saying that he believed that this was extremely important and that, we should treat patients not only with a cholesterol-lowering approach, but also with an inflammation lowering approach. So you have different people. I remember Dr. Lloyd Jones, who was the chair of the program at AHA when we did the session with media, actually, and was quoted saying that it's going to be very difficult to hold back on this following these results. So, but then again, yes, that's why you have a debate. And the person who wrote the editorial said just a word of caution. So I think globally people are leaning more towards enthusiasm and prescribing this, given that we reach our primary endpoint, that the drug is orally administered, that it is inexpensive, and the results are robust. But that's why, again, there'll be discussions. There'll be, I suspect, other papers. And actually, we will come in the weeks and months to come with additional papers that I think, to a certain extent, will even, strengthen the story. So we'll have to see what guidelines will say, and there'll be other studies to come. So, and then as far as your other point concerning CRP, I'm glad that you raised that point, because actually it did not generate too much controversy at AHA, but there was a discussion with reviewers before our paper was published in the New England Journal of Medicine. Maybe I can say what we saw was high sensitivity C-reactive protein, hsCRP, went down quite drastically, but in both study arms, both in the placebo group and the colchicine group, I have to admit I'm not too bothered by that because the natural history of CRP levels after a heart attack is just that. I mean, there's a massive increase at the time of an MI because there's acute exacerbation of inflammation, and then in the weeks to months afterwards, it goes down. So what we saw was a 65% reduction in CRP in the placebo group from baseline to 6 months, and a 71% reduction in CRP in the colchicine group. And the differential, which is the placebo-adjusted change, was 11% in the colchicine group, but was not significant. But I'm not bothered by that for a couple of reasons. A, the signal was driven by the natural history of CRP, and it was difficult to discern a colchicine effect on CRP because we only had a couple of hundred patients that participated in the biomarker sub-study, not the full 5,000 patients. So for me, these data simply mean that there'll be other mechanistic studies, both clinical and preclinical, that's going to investigate this. But, we know that colchicine is a powerful anti-inflammatory agent, and I have no reason to believe that it was not through that mechanism that it provided benefits to patients with a recent heart attack.
Yeah. Just to quote the editorialist, she writes that the result does not support the routine use of colchicine for secondary prevention without a better understanding of the absence of effect on death or MI. You make it clear that this drug was used in people with a recent MI, and so it's not to be put on your breakfast cereal or anything like that as a preventive. This is, and I think Harlan Krumholtz elsewhere made the point that further studies should examine which subgroups of people would benefit from this. But the thing that colchicine's got going for it is that it's inexpensive, and the side effects profile is pretty modest, except for a GI upset.
Yeah, I agree with you. And I think Dr. Krumholtz is absolutely right. First of all, strictly speaking, obviously, cold cut pertains to patients that had a recent myocardial infarction. So the debate is there in my mind. I, for one, would feel comfortable saying, for the reasons you mentioned, it's inexpensive, it's orally administered, it's safe, and we met our primary endpoint. I would feel comfortable prescribing it to patients with a recent myocardial infarction. Now, there are a couple of other studies that will come that will, shed even more light on this in other high-risk populations. For example, the LODOCO-2 study is going to be presented in September 2020. And this is in a population, it's the same size in terms of number of patients, but this is a study in patients with stable coronary disease.
I see.
And then we announced at AHA that we will be soon launching the COLCUT T2D trial in 10,000 patients with type 2 diabetes, but this time without known coronary disease. So we are going into high-risk primary prevention, and then we'll have to see what those results look like to see what kind of patients could benefit from that therapy.
Huh. And so are you involved with the LODOCO too?
No, not LODOCO-2. LODOCO-2 is being conducted in Australia and the Netherlands. Their study is fully recruited, and I'm the principal investigator of the COLCUT T2D trial that will be launching early in 2020.
And you'll launch the trial in 2020, and so we could get a report sometime early decade, you think?
Oh, sure. I think what will happen probably around 2025, we'll know whether reducing inflammation without affecting cholesterol can help patients even in high-risk primary prevention. And you're right. I mean, even though we're fairly excited about the results of COLCUT, as you correctly pointed out, this is in patients in secondary prevention after a recent myocardial infarction. So we're not talking about everyone starting treatment because they have hypertension or different risk factors. This is not what COLCUT was testing. This was a study of patients with a recent myocardial infarction.
All right. I want to thank you very much for talking with me today, Dr. Tardif.
Thank you so much. That was really a pleasant discussion.
That was our 244th episode. All of them are available free and searchable at podcasts.jwatch.org. I'd love your ideas on how to improve these chats. Email me, jelia@nejm.org. We come to you from the NEJM group. The executive producer is Kristen Kelly. I'm Joe Elia. Thanks for listening.